Hi, welcome to another episode of Everything Digital Health. I'm Marcus Bohr, I'm a GP and digital health specialist.
And I'm Nadia Kuftinoff, a digital transformation program lead at an integrated care board.
And we're just going to do an episode where we run through some of the digital health news stories of 2025, a bit of a review of the year, since it's that time of year when everybody does a review of the year. So we thought, well, why not? Before we get started, I'm just going to do a quick shout out to the NHS Standards Directory, which has been around for a couple of years, but I think it's been revamped recently. And they are currently looking for some user testing volunteers to help them to review the Standards Directory and get some feedback. So I'll put a link for you to get into contact with them if you feel you'd like to feed it back. So it's any potential user of this Standards Directory. Go to the site, have a little look at it, and see what you think as a digital health person. They are particularly looking for people who've got any form of accessibility needs.
It feels like 2025 has been a year of very big announcements, lots of big decisions, lots of new policy and strategy that has come out, and a lot of uncertainty as well is what I think I would describe this year as being. Just very uncertain for lots of different reasons for all kinds of different parts of the NHS. It seems that no one has come out unscathed of 2025. We've seen abolitions of NHS England. We've seen MARS and voluntary redundancy schemes start not just in integrated care boards but at trusts as well. We've seen a lot of arm's length bodies and quangos being told that they're not going to exist anymore. We've seen key organisations like the CSU being told that they're not going to exist anymore. There's been a lot of change and a lot of promise of change in a very short space of time, and lots of plans that feel they have been hastily made after the fact. So it's going to be really interesting to look back at 2025 and some of the key headlines across the country and the ramifications of those going into the next year.
Yeah, I think it feels like a lot of reform, but without a plan. I remember the Lansley reforms back in 2012, the sort of white paper came out and NHS England was born, and there was a lot about commissioning. But it did at least feel, even though that was massive change, it felt like there was more of a plan. Whereas this is, we're abolishing things and then we'll work out how everything fits together. And I think another theme is that a lot of the programs and the hopes for the NHS hinge on digital, and then a lot of the capability around digital is part of what's being axed. So I struggle to see how this is going to work out. But let's go from the sort of general into some more detail. So if we go and step through some of the interesting things that have happened this year. So 2025 started fairly quietly with the usual sort of January, February, not massive amounts happening. And then all of a sudden in March, there's a massive announcement that NHS England is going to be cut and completely abolished. And whilst we were reeling from that news, there was more news about the ICBs being cut by 50%.
It was a really big chain of events that happened in a short space of time, and the news just seemed to get worse and worse very, very quickly. So first we heard that NHS England was being cut by 50%. Then we were told it was being abolished. Then we were told that ICBs, integrated care boards, were also going to be cut by 50%. Then the news trickled out about all of the other cuts and abolishments happening across the health and social care space in terms of things like quangos. So Health Watch, for example, is allegedly going to go at some point within the next 2 years. And we found that the news was delivered in a way that caught, I think, nearly everybody off guard. So Keir Starmer announced this while he was at a press conference for something to do, it was nothing to do with the NHS, as memory serves. And I think at the time of the announcement, all of the CEOs for the integrated care boards across the country were in a meeting with NHS England, and as rumours go, in a basement boardroom where they had no phone signal. So they only found out about what Keir Starmer had said once their meeting had finished, and they emerged into into daylight and when their phones could get signal. So they came out of this
Ping,
meeting,
ping, ping.
to absolute carnage. So it just caught everybody completely off guard. And then the announcements just seemed to keep coming, and it caused a huge ripple effect. I mean, everybody was just in a fright from the get-go, but then we started to see things like recruitment freezes were happening, not just at the organisations affected, so NHS England and the integrated care boards, but trusts started to freeze recruitment as well, and that started a ripple effect where trusts started having their own mutually agreed resignation schemes over the course of the year, and people started talking about voluntary redundancy. But it all started with this press conference where allegedly the CEOs of the ICBs were in a signalless room where they couldn't receive any communications about what was happening, and it caught them off guard as well.
I mean, this is obviously, it's a BBC News website. It's not going to go into clear detail, but I just think you can't cut bureaucracy by creating more bureaucracy. And when you've got entire arms of government whose only weapon is bureaucracy, they can only create more emails and more PowerPoints and more reports and strategies. They are only ever going to produce bureaucracy. And if you want stuff done, then you need to have people in those organisations that can do things. And I think over the past decade and a half, we've systematically eradicated that sort of capability. So it's like, well, you can scrap NHS England, but essentially a lot of the functions will just continue to be exactly the same in Department of Health and Social Care. So I think there's a few layers to this. I think firstly, it's caused an enormous amount of human suffering because of all the people who've been caught in the crossfire of the uncertainty for the whole year. So that's ICBs, NHS England, all the quangos that are affected, anybody who gets their funding from NHS England, they have all felt this. And it's been a disaster, really, for them. So really, 2025 is like a lost year. No progress can have been made against a background of total chaos. And I've heard about meetings where really huge amounts of it has just been spent talking about essentially staff well-being because of this chaos that's going on. And of course, staff well-being is very important. But if we didn't have this chaos, the staff well-being would be better, and we'd be able to talk about the progress we want to make. Instead, we've spent an entire year just sort of circling the drain. So I've heard quite a few different takes on this. Some people are very pleased that NHS England is going because it's an unnecessary additional commissioning body and an extra step in the process. But I don't care. I've got to the stage where I just think restructuring and reorganising the NHS is not the solution because we've tried it so many times and it hasn't succeeded. So perhaps try doing something that's not just restructuring things. I'd almost welcome a move to say, let's leave everything exactly as it is in terms of the structure of the organisations for a period of time, for like 10 years, to let people embed and actually have stability on which to build new good things. You can't do good things on the background of total chaos and instability. And we found that, in the decision making of organisations, they all go into risk averse mode. They all go into sort of conservative thinking mode, which is like, well, I don't want to take any risks here. I'd be better off to, keep my head down as a manager, as a decision maker, as a board member, whatever. It's all, everybody goes into like damage limitation mode. Do as little as possible. Hope you don't get sacked.
I feel like this was a very knee-jerk decision, and we've got so many highly skilled quality improvement practitioners in the NHS, and I've only ever been on a course and done a little bit of quality improvement during my career in the NHS, but I think there's something to be said for things could have been done differently and in a more considered and measured way. The 50% number just seems quite arbitrary. It doesn't feel like anybody's actually gone in to individual integrated care boards or teams within NHS England to conduct a thorough evaluation about where there are inefficiencies and where things can be improved, processes can be improved, where meaningful restructure could happen. And yeah, it just feels like a number was pulled out of the air and there wasn't any real thought given into it. So we're just in this place where people are being slashed left and right. Teams are going to be decimated going forwards, and any restructures that happen it just feels very rushed, and there's not been a lot of consideration put into it at all. It could have been done so much differently, with a lot more thought and care, but this just feels absolutely brutal.
So next up we have something about us, which is that we started the Everything Digital Health YouTube channel in 2025. The first episode was myself and Joe McDonald talking about making medicine fun again, which were related to Joe's recollection of going to the HMMMMM Digital Health conference, which is in Las Vegas. It's very lavish, very expensive conference to get to, and lots of money is changing hands there. But one of the takeaways was that the advent of ambient voice transcription technologies, these AVTs, may well put some of the fun back into medicine by reducing some of the admin, some of the tedious secretarial work of our own clinical work, as in, typing up what we've just talked about with the patient, and instead shifting some of that work to ambient voice transcription services that will do that for us now. So potentially great stuff. If you want to hear more about that, there's a whole episode about it, and there's probably more to come to talk about AVT in itself, aside from Joe's excited HMMMM's discussions. But I'll put a link to that episode in the show notes.
So in May, we got a publication called the Model Integrated Care Board Blueprint, which kind of set out what the future of integrated care boards would look like. Now, this is, I think, the document where strategic commissioning started to enter the vernacular a lot more than it had previously. So we started to hear a lot about that was the function and the purpose of the integrated care board going forward. And it had some strategic shifts that were going to be the kind of direction of travel for integrated care boards going forward. So if we have a look here, we can see treatment to prevention, hospital to community, and analog to digital. Now, interestingly, analog to digital, there is a lot of digital in all of the plans about the NHS and strategies and policies coming out. But further down in this document, there is information about the functions within the Integrated Care Board and where they're going to go in the future. Now, because of the reduction of the ICBs, it meant that the structures of the ICBs are going to change. The digital functions of the ICB, by and large, just won't sit in Integrated Care Boards anymore. So they are going to be very much focused on population health management, and that falls under the data and digital remit. But things like digital leadership is going to move out of the Integrated Care Board, and I think is set to align to a national digital and data infrastructure, which is yet to be published or sorted out, I think. Digital transformation is going to move to neighbourhood providers over time. Neighbourhoods were another huge topic this year for lots of different parts of the NHS, social care, voluntary sector, a real push to pull everybody together once and for all. And we found that the neighbourhood providers that were mentioned where digital functions would go, they're not really a thing. Like, there are people involved in neighbourhoods, but there's not one singular neighbourhood provider, nor is there any funding confirmed for digital functions for neighbourhood providers.
This is exactly what feels like chaos.
Yeah.
Is that so? It's an analog to digital shift at the highest level. Lots of emphasis on digital everything. Great, but who's going to do it? Well, clearly not the ICBs, because they're digital. They've been essentially had the digital remit removed from them. And then some of that's going to go into neighbourhoods, but no one knows what they are yet. And I've heard lots of talking about neighbourhoods and neighbourhood ways of working, and essentially the more times I hear it in different settings, the more I'm convinced that absolutely no one has any idea what that actually means in practice.
So, I mean, we could do a whole other episode about neighbourhoods. And
We have to.
I work at an integrated care board, of course, so I've seen lots of interesting, good things happening with neighbourhoods and people really rallying together. But the maturity that they're expecting in the Neighbourhood Accelerator programme, I think, is quite high and perhaps unrealistic, whereas we've seen some neighbourhoods emerge, but it's taken a lot longer than 1 year or 2 years. Like, we're talking about a whole huge different way of working. So we might pick that up in another episode to kind of have a deep dive into neighbourhoods, because it is very interesting what's going on from all kinds of different angles and perspectives.
Yeah, I think it's absolutely need to cover that. So we're now on to June, and an interesting bit of a change of pace here. We've got something to do with health technology standards. This is a press release from via openEHR, but I think HL7 also made the same release, that there's an ongoing and active collaboration between these two health standards. So going back over the past, say, 10 to 15 years, a lot of the time they were seen as somewhat competitive, as though you can't have, you either structure your data in a FHIR kind of way or you structure it in an openEHR kind of way. And what's gradually happened is both have evolved, and it's become apparent that there is a space for them both and that they can actually work together. So that's a good news story, in that we've got two major standard development organisations that are working together to try and find the sweet spot for each of those standards and make it so it's easier to use them together. And there is even a possibility that some part of the reference model behind FHIR, which used to be HL7 RIM, RAM, which is a somewhat deprecated standard, could actually be replaced by openEHR. So there's some really interesting co-development where actually there will be, openEHR will be inside HL7 FHIR potentially. But the top level story is that, these are both now very active standards that are collaborating in an international space, and that's likely to be good for interoperability. Okay, now we're on to July, and we finally get the NHS 10-year plan. So I think the thing I was thinking when this all came out was, how is the plan going to reflect all these massive changes that have just happened? So the 10-year plan had been announced the previous September, October, that we were going to get a 10-year plan. And there was lots of consultation. And then in the meantime, there's these massive structural changes to NHS England, ICBs, CSUs, all the quangos, that must affect this and its delivery. And so it was kind of felt bizarre that we weren't getting the plan first and then the actions happening afterwards.
Wasn't the implementation chapter missing from the 10-year plan as well?
The implementation chapter was missing. So it's not a plan. I think that's the key thing. If you, in a word, the 10-year not plan, it's a series of wishes and nice thoughts about a fictional future in which more things are digital and everything just works. But I don't think any of the hard work has been done to get us from where we are now to where they want us to be in the 10-year plan hypothesis. If that is a good thing. I think there are a number of things that are either just too vague to actually have an opinion on, or are actively stupid. So, I mean, just casting my eye through some of it, there was things like AIs delivering allergy advice or something. There was something absolutely terrifying in the paediatric section, which is a bit I always go to because I spend a lot of time working in child health technology. So I was immediately looking at those sections. And so we've got My Children, part of the NHS app. So lots of stuff that's hinging on the NHS app. So the NHS app will be a kind of digital front door. But as Joe McDonald pointed out in his great little pre-Christmas editorial in Digital Health, the Mir space station was one of these modular things, and they added so many modules that gradually it fell apart and it became uninhabitable, and they had to just let it burn up in re-entry. And the NHS app could be doing the same thing. It's like, we'll add a module for that and a module for that and a module for that, and to the extent that it will eventually become unmanageable for the average person, because the average person is not a software developer. You know, you have to cater for a reading age of 8 or 9, and you have to cater for people who are not tech savvy, who don't have internet connections, who don't have a big mobile phone with a nice screen. There are people out there using phones that can't be updated to the latest iOS, for example. You know, that's your average person. And I think the governmental elite doesn't understand that, because they've never been exposed to that side of life. They live in a bubble in which everything is technical and everybody's got the money for the latest iPhone, and they can't believe that people might exist that don't have that. So I think Fit for the Future had enormous holes in it. We still haven't seen that implementation chapter. And I mean, it's more than a chapter. Implementation should be 10 times the size of the actual dream, as it were, because implementation is 10 times harder. But well, we shall see over the course of the next few years whether any or some of it gets done. But it doesn't feel very deliverable at the moment, especially with the sort of massive cuts going on in the background, the uncertainty, and the fact that goodwill has been lost. You know, if you want people to be excited about your new strategy, don't make them all redundant. Okay, so next up, here's something that happened in, we think, around August 2025, but we don't know because there was no announcement. I did an entire episode about this, and I'll put a link in the show notes if you're more interested in it. But essentially, NHS England, the Transformation Directorate, all of the bodies within the NHS sort of quietly abolished their open source policy. So they removed them from the websites. Now, I am going to do a formal follow-up video about it, but NHS England's response to this digital health news article was to say that essentially they were deferring to central government open source policy. And if you go to the gov.uk open source pages, they are excellent. There's a full service standard that talks about open source policy. What's difficult to swallow about that announcement is that there is absolutely no evidence of the NHS doing any of the things that are in the gov.uk open source policy. I mean, you could probably argue that that's also a problem at government level as well, but it sounds like there's a bit of lip service being paid to open source, but only the bare minimum. There's no resource going into it, there's no effort going into it, and deleting the open source policy web pages kind of reinforces that. It suggests they don't care. If you really did care, then rather than removing the pages completely, you would link to the applicable part of the gov.uk pages and say, if you're looking for the NHS ones, here's the overarching government-wide ones that you should be using. They didn't do that, which to me means that I consider their response to be just waffle. I'll cover that in a more detailed full episode in the new year.
So in September, we got another blueprint published. This time it was the Model Region Blueprint. We've got a nice summary there, which we will link to in the show notes. So the Model Region Blueprint is essentially trying to outline the 7 NHS regions, retaining their existing geographical footprint, I should say, as well, and the strategic leadership interface that they're going to present between national and local health systems. So the core purpose is to oversee regional health system performance, drive improvement and reform, playing as an integrator role between the centre and systems, as well as between systems, and also coordinate transformation aligned aligned with the national priorities that are coming out of the centre. So this blueprint was published. In the show notes, we'll include a link to an NHS Confed article, which kind of is a bit more of a deep dive into the blueprint and where it lacks certain clarifications as well. So the model ICB blueprint was quite good in as much as it could kind of specify where functions already existed and where they would transfer to, even if the transferring to was quite vague. At least there was a direction of travel in some respect, whereas the model region blueprint did lack a little clarification about where things sit presently and where they will go in the future. So again, it wasn't as clear-cut and as easy to understand as perhaps people had hoped. So still lots of uncertainty that's making it very difficult for people to plan for the future, to prepare for change, and to even understand like where things are going to sit. But it did provide some clarification on things going forward, especially in light of the model ICB blueprint. But again, these things have happened with a large gap of time in between them, so there has still been like a chasm of worry and speculation, and during that chasm is when people's anxieties start to heighten, and when morale starts to slump, and it's just more change and getting our head around things on top of change and getting our head around things, basically.
I must admit I get confused and completely baffled by the constant restructures and 7 NHS regions and fitting that in with ICBs, and then there seems to be such a frequency of these changes that I've sort of stopped trying to follow it, because it seems like just when you've got your head around it, it'll change anyway, so why bother?
I definitely have change fatigue at the moment, as well as everything else fatigue, and absolutely no morale left whatsoever. I'm sure this makes sense and is good, and there are good things about it. But for the life of me, I just can't get invested in it anymore. Earlier in the year, I wrote a blog comparing a lot of the things happening in the world of integrated care boards and NHS England, etc., to the television series Mad Men, because they actually go through a lot of change themselves as an advertising agency. So we'll link it in the show notes. But essentially, if you've never seen Mad Men, it's about an advertising agency in New York on Madison Avenue, and there are constant iterations of this advertising agency as they get acquired or bought or sold, or people leave or things change, and the final acquisition that happens and the merger, people just don't care for rousing speeches anymore. They've just completely given up. Nobody's paying any attention. People are just fed up to the back teeth and just don't want to hear anybody's talks about visions of the future and everything's going to be great. We just need to band together and it'll be fine. People are just fed up by that point. So.
Yeah, they've given up caring.
Yeah.
I think that might reflect where we are with the NHS as well. Who knows, maybe that's the whole point. Okay, so moving forward a little bit to October this year, we found out that Frank Hester had stepped down as CEO of TPP. For a bit of background, TPP is a company that produces the System 1 piece of software, which is used by something like 45% of GPs in England. So it's a big GP clinical system. The issue was that the previous year, Frank Hester had made some very, very out of order remarks that were widely condemned as racist and misogynist. There were other stories that emerged from practices within his company about racism that was endemic in the company itself, and that was March 2024. Frank Hester's also a very big Conservative donor, so there was suggestion that this was all a little bit unseemly. So very quietly, it looks like he stepped down, but I don't think there was any kind of an official announcement or whatever. And I think this is a face-saving move. I don't believe that it will have actually changed any of the control structure, command structure of TPP necessarily. If you go into Companies House, you can see that the new owner is actually Frank Hester's sister. So there's got to be some kind of line of control there. But anyway, interesting to sort of pick this up in the context of everything else that's gone on this year. And I suppose it's good that the pressure that was brought to bear by
the equity charter,
that did have an effect. Whether or not it's just a sticking plaster over it, does it really change anything? Okay, next up in November, I came across this gov.uk article, which is a little bit of a puff piece, like a lot of these things tend to be. But I find it really difficult when they say things like this. Patients will experience better care thanks to billions of pounds saved from ending duplication and slashing bureaucracy across in the NHS, the Health Secretary will announce on Wednesday. And I know that gov.uk tends to just be a mouthpiece for the government, and it's uncritical by its nature. But I just guarantee that it doesn't matter how much money you save by ///, saying that will deliver better care is firstly, it's very difficult to verify. But secondly, I think it's very difficult to make happen, because when you slash money, and if that money becomes available for something else, immediately the big corporations dive in and install themselves with new federated data platforms or single patient records. There's always something that can absorb that money in a more rapacious way than allowing it to trickle down back to the front line where it can deliver better care. I'm not convinced at all that you do get this trickle down effect.
I think it's a very broad brush stroke here. So patients will experience better care is not specific at all. It sounds good, and it's a statement that everybody can get behind. Yes, of course we want patients to experience better care. And if that's because of the billions of pounds saved from ending duplication and slashing bureaucracy, well, then that's a good thing. But what it's not saying is which patients, like which cohort of patients. And you could argue, well, there's too many cohorts of patients to list here, but even just a couple of case studies or examples would be great. Like, which patients are going to get better care? What does that better care look like? What pathway are you redesigning or reinventing? How are you going to do that? Is that using resources we already have, or do we have to introduce something new? Who's going to be doing that? Like, what do the project teams look like? Again, are those people that already exist? Like, it's just a very broad statement, and broad statements like this have been used a lot in the past to rally support and make people think that is the correct thing to do, therefore we must do it, without actually having more information about the pros and cons of that approach or the risks associated with what they're doing. It's just it's
I think
not nice.
Dead on. So the idea that abolishing administrative posts will definitely result in that money redirecting to frontline patient care is an untested hypothesis. I think you could make sure that happens, but will it? Because there are always very hungry mouths within government and the sort of cadre of spending pots. There's always ways that can be sucked out into things that also don't deliver frontline patient care. It also assumes, firstly, that none of those administrative posts were doing anything, or that they were actively harming patient care. So we had administrative posts that made it harder to deliver patient care, and by abolishing them, redirecting the money, suddenly everything becomes easier. My experience of frontline care has always been that there's not enough administrative work going on, and that so you end up with frontline staff, nurses, doctors, midwives, doing their own admin. And that's got to be far more wasteful.
Something really interesting there. The every £1 billion saved in bureaucracy costs is enough to fund an extra 116,000 hip and knee operations. That sounds good, but I'd love to see, like, what are the waiting lists for those hip and knee operations, and is it just money that is preventing those hip and knee operations from happening? Like, there's a lot of contributing factors to why waiting lists are so long and why people aren't getting the operations that they need. And saying that it's all just because of money, like if we just throw money at the situation, we'll be able to pay for the hip and knee operations in this instance, But why is that such a problem in the first place? Like, what are the underlying issues as to why we need more money for these operations to happen? What about other operations? Like, is that £1 billion, is that all we can afford? Is just those hip and knee operations? Like, it seems like an economic analysis. I mean, you can't go into it into one article, obviously, but it just makes me really angry that things like that will be plucked out and popped into an article, and there's no further detail. It's just things that will make you go, oh yeah, that sounds good, I support this.
I guess this came out near the budget, so it was all about essentially a boost for the budget to make it sound good. The NHS is always a good thing to talk about in the budget, because unlike other forms of spending, the NHS generally is always seen as good spending. So more spending on the NHS is good, but if you said you were going to spend a similar amount on education or roads or the military, that would be much more complicated. So I think they tend to, around the time of budgets, they go towards the NHS because it's kind of like it's motherhood and apple pie. It's always a good thing to be spending more on the NHS, especially if you can reduce inefficiencies, which is also a great thing, even if you don't know where the inefficiencies are. We have the first reading in Parliament of the Cybersecurity and Resilience (Network and Information Systems) Bill, which is obviously still going through the legislative process, but it's one to keep an eye on, and I think possibly something we'll cover more in 2026, when hopefully, presumably it will have been ratified and we'll actually have something concrete to talk about. But I think the key thing for me about digital health is that our networking infrastructure, our cloud infrastructure, and our key systems are all very, very much dependent on other countries. So, for example, American mega suite hospital systems. And I think what is starting to become apparent in the current world order is that things have changed about our relationship with the United States, and we can't necessarily rely on them to always be the player that we needed them to be, and how they've behaved in the past may not reflect how they'll behave in the future, meaning that it's very dangerous for us to have so much of our critical national infrastructure entirely dependent on United States owned corporations. It's not that difficult nowadays to see that conservative and that kind of political worldview that is essentially the MAGA worldview is starting to taint how corporations are acting, because the corporations are afraid of incurring the wrath of Trump, so they agree to do whatever Trump says. And if that means, as the news story from earlier this year, where there was a whole load of contraceptive pills that had been paid for by US aid that were going to be destroyed because the conservative right don't like contraception, and that nearly happened because Trump decided that was what was going to happen. So is it so far-fetched now to imagine a time when a similar executive order could say United States healthcare systems can't be used to run a contraception clinic or an abortion clinic, something like that? And regardless of anyone's views about those specific issues, what I'm talking about is it's the sovereignty. It's the fact that another country and their policies could potentially make it impossible for us to deliver healthcare in this country because of an over-reliance on those systems. So it'll be interesting to see how that reflects in this legislation and whether it's even mentioned at all, because I think it is starting to get there, where European governments are definitely waking up to this issue after the International Criminal Court. Some key members of that court lost access to their Microsoft accounts in something which seems a little bit too coincidental, and right after they had announced an arrest warrant for Benjamin Netanyahu for genocide in Gaza. That's the sort of thing we're talking about. It's when governments start to realise that the digital infrastructure they're using is vulnerable to not necessarily hackers, but just literally the corporations that own them saying you can't use it for that, or we control it, we're taking it away from you. We disagree with your viewpoints, we're going to prevent you from using these digital solutions. So we definitely need to start thinking seriously about digital sovereignty as part of cybersecurity and resilience. And following on directly from that story, here's a similar one about MPs calling for the NHS to rely more on UK tech firms. And I think it's very important that we do pay heed to this. We do need to start taking control of the digital infrastructure that we have. It doesn't necessarily mean ripping everything out and replacing it. You can start small and just reduce total dependence. So by just having other options available, you start to get to a point where there are paths forward that don't require, for example, Microsoft, and don't require Oracle, don't require Google. You need options, and clearly, the Science and Innovation Technology Committee has caught on to that as well.
And now we're in December, and I think one of the biggest pieces of news that we've had for this month is that the voluntary redundancy schemes have launched in NHS England, and I think most integrated care boards have launched their VR scheme by now. I know that the South East ICBs did try and coordinate their schemes to open all at the same time, but I think the rest of the country has caught up now. So the VR timelines are such that applications for lots of ICBs will have, the deadline for application will have passed by now. Some application windows close early in the new year, with a view that I think countrywide, anybody who's applied to take voluntary redundancy will have left their organisation and the NHS, I suppose, by the 31st of March. Right. Now, if you don't work in an integrated care board or NHS England and you have questions about what does that mean, and questions about like the clawback periods, things like that, happy to do a video on that if people have got queries about it, just as a broad overview in terms of what it means for people and the considerations that we've all had to take in applying for VR or not. There's a lot of talk, I think, about how the applications for voluntary redundancy have been quite low. That might just be a Southeast integrated care board thing, but it seems that not as many people as perhaps the government were hoping applied for VR. They did end up changing the clawback terms recently. So clawback is essentially saying if you join the NHS again after a certain time period, depending on if you're voluntary redundant or compulsory redundant, you have to give your redundancy payment back, and the list of organisations where clawback was applicable was, I think, in excess of 600 at one point, and now it's been dramatically reduced. So now you can apply for roles in local authority, whereas before the rules were changed, you couldn't. So it was kind of every single public sector role was subject to clawback, and now they've reduced that to, I think, encourage more people to take voluntary redundancy. Why voluntary redundancy versus compulsory redundancy? I think it's a matter of timing in terms of the money for voluntary redundancy is being considered an overspend for this financial year, which has been agreed centrally for integrated care boards, whereas compulsory redundancies will fall out of the 25-26 budget and will therefore cost more, in quotation marks. They take longer as well. There's lots of reasons why I think voluntary redundancy is just easier for integrated care boards and NHS England to process and to manage going forward. There is an argument that waiting for compulsory redundancy there isn't really a massive benefit to it, but it depends on who you are, how close you are to pension age, waiting for another year to be added onto your continuous service. There's pros and cons for everything. Like I said, if anybody wants a video kind of going into this in a bit more detail, because I'm sure it's still a mystery to lots of people who hear about it and aren't directly involved in making the decision of voluntary redundancy or not.
Yeah.
But it did finally happen. We got some schemes that finally launched in December. So it only took, 8 months?
Yeah, practically an entire year of uncertainty for people.
Yeah.
I think also this is worth pointing out that it completely belies the idea that by making a lot of administrative posts abolished, that you've suddenly freed up billions of pounds, because you don't just abolish any of these jobs. You have to make people redundant, and that costs money. So it's actually going to overall cost the NHS an absolutely phenomenal amount of money in order to close down jobs which are supposedly wasteful, but I haven't seen any evidence that they are. And although there's certain to be waste within DHSC, NHS England, all the ICBs, I don't think we know clearly enough where the waste is to be able to just say, get rid of 50% of it, sounds about right. Yeah, 50%. It's just a made up number.
We're also asking people to make these decisions ahead of structures being released. So, for example, for integrated care boards, mine is clustered at the moment with our next door integrated care board, but going forward we are restructuring like it's a new organisation totally, and we're taking a bit of the ICB next door and amalgamating it into ours, and we can't see any consultation documentation while we're making the decision about whether to apply for voluntary redundancy or not. So this is a decision that's being made in the dark for, I think, the majority of people who work at integrated care boards. So we don't know what the new integrated care board is going to look like. Therefore, we don't know if we are at risk of redundancy in the first place. And it's a very difficult decision to make with absolutely no information to help us make an informed decision. It's a stab in the dark.
Yeah. However, I can completely understand why there'd be a lot of people who would essentially just say, look, I've had enough now of endless restructuring and never really being given the resources to do your actual job either. When in between restructures, it's always so constrained that you spend your entire time managing the constraints and not getting anything done. So, I can imagine that a lot of good people will be lost from the NHS and its surrounding services through this kind of wastage programme. And they'll go off and do cool things outside the NHS, hopefully.
I hope so. And I hope that the people who stay, it's not too horrible for them. And I really, my heart goes out to everybody who's in this position, because I'm in it myself and I know how difficult and horrible it has been. I'm just fingers crossed for the future that things work out, but it's a nightmare that we're in this position in the first place.
Okay, that's all for our little wrap up of 2025. If you've got comments about what we've discussed, then please obviously just chat down below and let us know what you think. If you've got news stories that you think we've missed, obviously, we've had to condense a whole year down into just a couple of the things that I think were key. I tried to pick things from different parts of digital health, the political stuff, the NHS stuff, the standard stuff, all over the place really. But by all means, share things that you think are significant that we've missed. And like always, we're going to continue to do this. We've found it really interesting and fun to bring together some digital health stories over the course of 2025, and so we'll be continuing to do that into 2026. So if you've got ideas for episodes, then you can always contact us on the email address that's in the show notes. And don't forget to subscribe if you find this content interesting to you, so that you don't miss an episode. Let us know what you'd like to see on the channel, and share it with other colleagues that you think would find it interesting. So from us at the end of 2025, thank you for watching whatever you've watched, and well done for sticking with us for this long. Bye now.